Okay, it's 5:33, so we're going to go ahead and start. So welcome and good evening, and thank you for joining us in our virtual community lecture to talk about hip and knee pain. My name is Ruth Tasfay. I'm the Orthopedic Spine Program Manager, and we have joined by our orthopedic specialist, Dr. Andrew Wassev, for this lecture here. Before we start, I just wanted to let you know that this webinar is about an hour long, and we'll have plenty of time, hopefully, at the end of the lecture to answer any questions. So I will recommend if you have any question, please write it on our Q&A and then throughout the lecture, and we'll be able to hopefully address answer all your questions the best as we can. Unfortunately, we're not going to open it up to audience asking questions directly, but we'll try to answer questions through the Q&A. Before I introduce Dr. Andrew Wassev there, I wanted to, we're joined by Bob Lehner, who's from our foundation medical foundations, and he's going to be sharing with us some information about open enrollment. So Bob, go ahead and share your information.
Okay, Ruth, thanks for the introduction. As Ruth said, my name is Bob Lehner. I'm the Director of Marketing for the 3 LA medical foundations that are here in Los Angeles. What this group has asked me to do over the next couple of minutes is really to give you an idea of what we do in terms of what we call Medicare open enrollment, or in terms it's called AEP. So what I want to do today is share with you a little bit of information. The fact that the annual enrollment period, which starts October 1st and it goes through December 7th, is really important for us. From a standpoint from Providence for the South Bay, what we try to do as an organization is to provide the best information possible, to provide sources for you to connect. If you're interested in getting a new Medicare plan or getting what they call a checkup every year in terms of what's going on. What we do as an organization is we get information out a number of different ways. And what I'm going to do is show you very quickly, because like I said, I only have a minute or two to take you through the fact that when you see these ads, when you can get information, you can find out that we have several sources, again, as I mentioned, that you can make a phone call or what have you in order to get that information. So as I share my screen, so what I'd like to do is on the screen itself is that what I'd like for you as individuals to do is to look for these different communication pieces if you're interested in looking at a new Medicare plan. In the South Bay area and the Daily Breeze, we're going to offer, we'll have newspaper ads. In each of the newspaper ads, we're offering virtual meetings. We're also looking at doing face-to-face meetings depending on what's happening with the variant, covariant. There will also be, we'll also have, if you're on your computer, you will see digital ads that will look much like this. A lot of our messaging has to do with zero premium. The fact that we offer, working with the health plans and working with the brokers, that this is an important part of our message in terms of making sure that you get the right plan that fits your healthcare needs. We have direct mail that's going to go out to everyone in the South Bay, both from a patient standpoint as well as from non-patients, and you'll be receiving this information. In these direct mail pieces, there'll be inserts in terms of giving information on virtual meetings and also face-to-face meetings. The most important piece here is that if you are a patient of one of our physicians, one of the things that you'll find in the offices starting October 1st, there'll be a brochure that you can pick up at each of the offices. And it provides a comparison sheet in terms of fee-for-service Medicare versus MA in terms of cost benefits, in terms of what's going through there. On the left-hand side, you'll see in this brochure that there will be 4 ways that you can get information. We work with an online broker. We work, and they have either you can call or you can go on their site to compare plans that we're contracted with. And then you can go to a meeting. That's really important in terms of what happens. Or you can talk to a local broker that works with each of our offices. So that's what I have to talk about today. I just wanted to give you kind of a brief information piece in terms of what we're planning on doing, how we're going to disseminate information, how are you going to get that important information on finding out about Medicare. Anyway, Ruth, that's it.
All right. Well, thank you, Bob, for sharing that information with us there. So a little bit about my job, what I do here. Like I said, I'm the orthopedic program and spine, orthopedic and spine program manager at Little Company Mary. As most of you probably know that, we are part of the Providence system here. We are part of the 50 over, plus hospitals west of Mississippi. And we treat the second most total joint and spine cases in the nation. And so we're part of that bigger family here. I work very closely with the surgeon, with the team here. I coordinate the care for anybody who requires any kind of treatment for a total joint or spine. And I really feel like we have a very robust program here. And if you want more information about our program here, please, there's a link on the chat box. Please, use that to explore all the services that we provide here. So now it's my pleasure to introduce you to Dr. Andrew Wassev, and I want to give you just a little bit of background about him. So Dr. Wassev is a board certified and fellowship trained orthopedic surgeon, specialized in minimally invasive surgeries and robotic assisted surgery. He has a special focus on joint replacement in the mostly younger population. Dr. Wassev spent time teaching surgeons worldwide about how to adopt robotic assisted surgery into their practice, and currently serves as a teaching consultant for Mako robotic assisted surgery there. He has an interest in revision surgery, complete revision, and revision of failed total joint replacement. He received Vinyl's Patient Choice Award and Compassionate Doctor recognition from 2014 to 2018. Dr. Wassev is married with 2 young children and an active member of the South Bay community. In his spare time, I don't know when he finds a spare time, but he enjoys golfing and spending time with his family. So without further ado, Dr. Wassev, please take it from here.
All right, thank you very much, Ruth. Thank you, Providence and Little Company, for inviting me here to talk, and thank you all for taking time out of your day to spend an hour with me. I'm going to go over, hopefully, some topics that will interest you, and we'll try to make this as informative for you as I can. I'm just going to share my screen here. Okay, you can see me well. So, as Ruth said, I'm a fellowship trained joint specialist, so basically spend an extra portion of my training, an extra year, just doing joint replacements. I've always had a focus on robotic assisted surgery. I think it's really a revolution that's occurred. Providence has been smart enough to invest in that pretty early on, and at Little Company of Mary Torrance, we have 2 robots actually that we use for our joint replacements. So we'll discuss that quite in depth during the talk here. So first of all, we'll talk a little bit about arthritis. So half of Americans diagnosed with arthritis don't think that there's really much that we can do to help them. Arthritis is actually the #1 cause of disability in the US, and it really limits your everyday activities pretty significantly. There's not a lot you can do in a normal day that arthritis does not affect. The cost of arthritis to our US economy is over $128 billion annually. So over 16 million adults say that arthritis limits their usual activities in some way. Only about 1 in 20 report work limitations. And that's really where we see the cost in terms of the economy. By 2030, we're estimating that a quarter of the projected total adult population will actually have doctor-diagnosed arthritis, which is really pretty significant. These estimates are somewhat conservative because they really don't account for the current trends in obesity. And there's a lot of reasons of the increasing population of arthritis, and many of that has to do with more active lifestyles at a younger age. Sports wise, we're pretty progressive these days, and it's much more aggressive, I think, than we were in the past. So we do see a lot of injuries that result in arthritis. Total joint replacements can save an individual as much as $68,000, for a total knee, or $180,000 for a total hip replacement, and that's just in medical costs over the life of an average total joint recipient, as compared to non-surgical treatment. And really, the goal of us as an orthopedic community is to keep you active. Whether it's non-surgical or surgical, our goal is to keep you active, to keep you enjoying your lifestyle that you want to enjoy, and hopefully really reduce your pain. So first of all, the proper diagnosis is the key to a successful treatment plan. So really, it starts with medical history, examination, obviously, of the affected joint, radiographs, very helpful. But I'll tell you, in my practice, the majority of my diagnosis comes from what you tell me. You guys as the patients really know your bodies best, and what you tell us is extremely important, because I think, every surgeon has walked into a room and seen an X-ray with, 2 hips on the screen, and the right side looks extremely arthritic. And the first thing we go is, we start examining the right hip, and they're actually here for the left hip, and the right hip doesn't bother them, even though the right hip is arthritic side. So really what's critical is what you tell us, and that's what we're here to treat. So factors that increase the risk for osteoarthritis, lots of factors here. This is a busy slide, but really quick overview. Systemically, there's age, gender, definitely a lot of genetics that we're still really learning about. Even for the wear and tear osteoarthritis, there is a strong genetic factor to it. You can have injuries, there can be malalignment that can predispose you to arthritis. And then, of course, traumatic injuries, repetitive stress, some, certain jobs and lifestyles where you really repetitive high impact activities can definitely predispose you. Weight, we talk about quite a bit. And the reason being is that excess weight puts a lot of stress on the joints, as you can imagine. Body mass index is something that we refer to, and that's basically looking at your height versus your weight. And what we've shown is that at a higher BMI, your radiographic osteoarthritis increases pretty significantly, over 5 times when your BMI is over 30. And if you're anything like me, I'm in and out and ordering 2 double doubles, but I can't imagine not getting a diet soda. So I think we all have to pick and choose our battles and pick and choose what cuts we make. And so I think we've all, especially with recent events, we've all struggled with weight gain and weight loss, and I think most of us do over our lifetime. So it's important to stay active, try to keep your weight down, to a reasonable weight, so that way you help keep the joints less stressed. Every extra pound on your body is about 3 to 5 pounds of pressure. So when you think about losing 10 pounds, that's like losing 50 pounds of force through every step you take in your knees and your hips. That's pretty significant. Of course, excess weight can accelerate the rate of cartilage destruction. And it obviously makes it harder to exercise well prior to surgery and as well, after surgery. So conservative treatment options for arthritis, activity modifications, sometimes lifestyle changes. There are people that will give up certain things that they enjoy, such as golf or tennis, just to try to reduce their symptoms. That's not always acceptable option for people, but initially sometimes that does help to calm things down. Diet, exercise, medications such as anti-inflammatory medications, supplements, walking aids, rest and ice, and physical therapy can all be very useful. So when we look at exercise in treating knee and hip osteoarthritis, regular aerobic walking can be very useful. Quadricep strengthening exercises can actually increase can decrease the risk of osteoarthritis by about 30% when you increase your strength by 20%, which is a pretty substantial number. So what happens when you strengthen the muscles around the joint, it actually helps to not only kind of distract the joint and reduce the amount of stress that it sees, but it also reduces the symptoms around the joint. And then water-based aerobic exercises is also really, really great because you can be in the water and not really feel the stresses of gravity and still exercise the joints and get a good aerobic exercise. Braces and self-help devices such as canes. Canes can reduce the stress across the joint pretty significantly. One thing I'll say is I have a lot of patients that come in and they're using a cane on the same side as the injured or hurt leg, and it's actually you're supposed to be using the cane on the opposite side. It's somewhat not intuitive, but it actually substantially decreases the reactive forces when you're using the cane on the opposite side of the injured leg. And then crutches and walkers obviously can help with balance. Bracing and assistive devices, hinge knee braces and unloader braces, we call them, which kind of help tip the knee in one direction or another to reduce the stresses and the forces that the knee see through every step, can also be quite helpful for people. And then also a cane can decrease joint forces by 50% when used correctly. And then injections, cortisone injections. I think cortisone injections have gotten somewhat of a bad rap. I think there's a use for it when it is done properly in the correct patient. I've personally had cortisone injection. I have a semi-arthritic hip, and it made a pretty substantial difference for me. They're given much more often with knee arthritis than they are with hip arthritis. However, they can be quite helpful in both. And cortisone is just a very potent anti-inflammatory, which can really just reduce the symptoms for a period of time. And then there's the intra-articular hyaluronic acid. We call them, gel injections or viscosupplement injections. Those can be very effective in knee and hip arthritis. However, they're only FDA for knee arthritis, so that's really where the insurance coverage comes in. It's more of a delayed effect than cortisone. Cortisone tends to work quite quickly within a week or two max. The gel shots sometimes take 3 to 4 weeks to really kick in maximally. However, they tend to last longer when they do work. So patients that have good results with the gel injections tend to get 6 to 8 months, sometimes even longer with, results with the injections. And sometimes it's one injection, sometimes it's a series of 3 to 5 injections, just depending on the brand. There's also glucosamine and chondroitin. A lot of people ask me about this. My mother-in-law swears by OsteoBiflex. I'm not, there's no right or wrong answer for this. I think there's a lot of research on this, and there's really no definitive answer. What we have seen is that there are some patients that when they take it have a reduction in symptoms. Scientifically, we haven't been able to completely understand that or really explain it. What I would say is, I tell my patients, if you want to try it, I think it's very reasonable. Try it for 2 to 3 months. If you try it for just 1 week, you're never going to see an effect with that quickly. So you have to give it a real shot. If you're going to try it for 2 months, 3 months, if it's not helping, then there's no reason to continue doing it. There's no real scientific obvious proof, but if it is helping, then great, then you can continue to take it. When you look at the background treatment for total joint replacement, it's really one of the most successful surgeries that's ever been performed. And that's not just really in orthopedics, but that's just across the board. It's just a very, very successful surgery. It's got excellent survivorship. Even when you look at the surgeries that were performed 25 years ago, and we kind of feel like that was archaic back then, what they did compared to what we're doing now, it still had, excellent outcomes and great survivorship. If you look at the volumes now and the estimations of where we're going with the projections, it's really pretty shocking. You know, we see more and more patients that require total joint replacements. And when we see, you know, when you look at this graph, there's one line showing primary total joint replacements and there's one showing revision. So when we say revision total joint replacements, that's redoing a joint that's already had a total joint replacement in there. There's a number of reasons why that can occur, and we'll talk about that a little bit more later. However, as you can imagine, with all the joint replacements that have been done in the past, as time goes on, some of those are going to need to be redone, and the more that are done, the more are going to have to be redone. So we're seeing a very large influx of total joint replacement patients, and it will continue to really drastically increase over the years. So a little bit of in terms of tips for people considering joint replacement. There is a somewhat of an optimal window of opportunity for treatment. You don't want to be too early and you don't want to be too late. We have clearly seen that patients who have, you know, very low radiographic findings of arthritis, however, significant pain and have a joint replacement tend to not do nearly as well as patients that do have, you know, enough arthritis on x-ray and have the surgery. However, people that wait for their arthritis to get out of hand and they begin to have a pretty severe deformity, the outcome is definitely not as predictable, and the recovery is more difficult. So you don't want to wait for the symptoms to become too debilitating. You don't want to wait till you lose your muscle mass until you really become debilitated. So you want to kind of be in a point where you're ready, but you're not you're not overcooked. So a little bit about what we're seeing in terms of the paradigm change in activity level after total joint replacements. You know, we're seeing younger and younger patients that are much more demanding. A lot of patients in their 50s and 60s and very active 70-year-olds, and they're, you know, they're playing tennis and they're playing golf, and, you know, they're running here and there, and you know, we are much more comfortable now, I think, allowing our patients to perform activities that in the past we may not have been, somewhat due to the advancement in our operative techniques, but also really better materials. And then also we have a much different patient population than we did 20 years ago when we were doing total joints. Now our patients are, you know, they're younger, demanding, and they want to live their life and enjoy life. And that's what we're here to help you keep doing. So if you look at the shift to demographics, it's really, you know, the 65 and older group is a much smaller portion of the patients that are having total joint replacements now than they were in the past. You know, previously it was pretty rare to have a total joint replacement under the age of 65. Now that's a pretty substantial portion of my patient population. So a little bit about the hip joint. It's a real ball and socket type joint. There's the head of the femur, which is the ball, and then at the top, the roof, we call the acetabulum. That's the socket, and that's what creates a ball and socket joint. Arthritis is the most common cause of hip pain. However, there are other types of issues that can affect the hip. But osteoarthritis, the wear and tear of type of arthritis that we talked about. There's also different types of arthritis, such as traumatic arthritis, where someone may have had a fracture of their hip, a break, or a dislocation or something like that. And in time, that can go on to end up in pretty severe arthritis. And then there's also inflammatory arthritises, which are much more genetically based. And, you know, most people will have a family member with it. And that's, you know, rheumatoid arthritis, the most common one. So if you look at an x-ray here, we see on the left-hand side, the healthy x-ray, and the healthy x-ray you see has a socket and then the head, and in between you have space, and that space represents the cartilage. So in an x-ray, we don't see cartilage. Space helps us, you know, evaluate the cartilage level. So on the right side, you see there's zero space in between the socket and the head, and that's really, you know, severe bone-on-bone arthritis, we call it. And you can see those sharp bone spurs also, we call osteophytes, that begin to form, you get reactive bone that forms due to the chronic inflammation secondary to the arthritis. There's also the inflammatory arthropathies, we call them, where this is actually a good friend of mine who had ankylosing spondylitis, which is a different type of somewhat like rheumatoid arthritis. And you can see his left hip actually completely fused over the years. And this was, kind of started for him when he was in high school, and it progressed. So, there are different types. And post-traumatic arthritis, someone who had a fracture that was not treated, was missed, and they end up with severe arthritis from old injury. And this is the hip replacement that was performed to help treat that injury. So what you need to know preparing for your visit, it's always good to try to think back about your medical history, because that's very important for us. That gives us a real thorough understanding of where to start. A physical exam will be performed, x-rays almost always taken, and then obviously additional tests, laboratory tests sometimes if we're suspecting some kind of inflammatory arthritis. We'll talk a little bit about recent technical advances, and I think this is, some of the more exciting parts of the talk here. I won't bore you too much with the rest of arthritis, but when you look at the technical advances, first, it's good to understand how a standard total hip replacement is performed. So what we do with a normal hip replacement is we call it a femoral neck resection, where we use a saw to cut the neck of the femur, and we remove the diseased head. And the femur is a cylindrical bone. So we open the center of it, and we carve into it. We call it broaching. You're basically carving into it and putting a stem, which is a fully titanium stem with a roughened surface at the top. You can see it's smooth on two sides, and then there's a roughened portion. That roughened portion in the center actually looks like bone. The porosity is very similar to bone, and your body looks at it like bone and actually grows into it. And that's how it successfully becomes yours. One critical aspect of this is obviously putting in the correct size, because there's many sizes and everyone is different. And so putting it in the correct position and the correct size is very important. Same thing with the socket. We're using a very expensive cheese grater, and we're basically removing all the bad cartilage and the eaten up bone, and we're putting in a socket that is also titanium and a titanium backing, and the bone will grow into that as well for successful treatment. And then in the middle, there's a head that we put onto the stem, and that head sits into the socket, and that's how the hip joint works. Now, with a knee replacement, very similarly, it's more like a resurfacing procedure. We don't cut the whole knee out and replace the whole knee, only in extreme circumstances, usually for tumor. But with a normal knee replacement, it's more like we resurface. We kind of carve out the bad edges of cartilage and bone, and formulate a receiving surface on the bone for the prosthesis. And the prosthesis is a metal cap on both sides, and then a plastic, very durable plastic called polyethylene in the middle. And that is what kind of acts like the cartilage in the center. So I'm going to talk more now about Mako Smart Robotics. So Mako technology is a robotic assisted arm platform that has really changed the game, and it's really created an evolution and a revolution with total joint replacements. The robotic arm does not perform the surgery. Many people ask, many patients get kind of nervous. Are you going to be in the room? Are you just going to hit the start button? And we are definitely in the room and in charge. What it is a very, very powerful tool to give us not only preoperative information, but also intraoperative information during the surgery that is extremely helpful for us. The technology is very safe. It's been around for many years. Millions of surgeries performed robotically have been performed, and it's really, I can't imagine in another 10 years that there will be very many joint replacements not performed robotically assisted. The surgeon is always in charge and always guiding the robotic arm. The robotic arm is just used to keep us in a very strict boundary from the plan that we formulated specifically for your anatomy. So you can imagine the soft tissue damage and the overall safety is actually much higher because we are strictly bound, and it's not a saw that can kind of go out of any bounds. It's really kept in a very small area. So with hip replacement, before the surgery, we get a CT scan for both the hip and the knee replacement. There's a CT scan that we get, and the CT scan doesn't go only through the affected joint. So if you're having a hip replacement, it's not only through the hip itself, it goes through the entire pelvis and it goes down. So that way we can actually know your lengths of your hip. So we have an idea of whether or not you have equal lengths. We have a very clear picture per millimeter of what changes we can make during surgery to be extremely precise. And the same with the knee. The knee goes through the knee, but it also goes through the hip and the ankle. So we know your angles, we know your anatomy, we know your size. All these things are predetermined. So when we get to surgery, we already have, 80% of the surgery almost done in our mind. We really have a very clear idea of what we need to do to execute it perfectly for our plan. And then the robotic arm is used to prepare the socket on the hip side. And once we finish and put the implants in place. Now with hip replacement, what's critical is actually how you put the cup in. So when you hear about complications of hip replacement with people that have dislocated or people that have leg lengths that are unequal, all that can be drastically reduced with robotic assisted surgery because we're putting the socket in the right place every single time. And the right place is still determined by the surgeon, but there's so much information that we're given prior to performing the surgery that we really are able to execute and hit the bullseye. And during surgery, once we've actually put the implants in and prior to completely finishing, we actually get to, really see what we've changed per millimeter in both the length and we call the offset, which is the mechanical advantage that we give the hip. And so we're able to recreate the center of rotation of your hip perfectly. And we're able to actually make your hip feel much more natural, which I think in my practice, it was a very obvious shift in terms of how people were recovering, how quickly they were recovering, and how natural they felt. There's something that we call the forgotten joint score, which I think every surgeon really, it's the holy grail. We want every patient to come back and say, oh, I forgot I had surgery. That's the best compliment you can ever give me. If you come back to me and you say, yeah, I forgot you even did my total hip. I don't feel like I had anything done. That's the best thing, because we just want you to get back to life and forget that it really ever happened. And robotic assisted surgery has really significantly improved our ability to do that in a much more reproducible manner. Now, this is a busy screen, but what you can see is prior to the surgery, we're able to, again, see your anatomy, and we're actually able to take you through a virtual change and a virtual range of motion planning, which is, it's really mind-blowing how exciting the technology is. It's crazy how far we've come, but we're able to actually put the implants in and check all the changes prior to doing the surgery, so we know exactly what we want to do when we get in there, and we're able to execute it properly. There's a great study that was done on a surgeon, Richard Ilgen. Rich he's a very skilled surgeon, very well trained. He was trained at fellowship at Harvard, Mass Gen, had a very busy practice for 10 years. They looked at all of his cases, and he's a very well-respected guy out there. First 100 cases in clinical practice, he had a 5% dislocation rate, and 40% of his cups, the sockets, were put in the target range. If you look at his last 100 cases before he started robotic assisted surgery, he still had a 3% dislocation rate, which was an improvement, 2% improvement, and 48% were within the target zone. If you look at his first 100 cases with Mako robotic assisted surgery, he has a 0% dislocation rate and 76% in the target zone. That's a very, very strong study. I mean, when you look at that, you got a guy who's very successful in 10 years of a very busy practice. he was able to reduce his dislocation from 5 to 3% only. In his first 100 cases with robotic assisted surgery, he dropped that to 0. So it really is a pretty amazing technology. Same thing with the knee. You know, we always say no more and cut less, because we're able with the CT guidance to really only take the bone that we need to take. So we are definitely taking less bone. When we did total knee replacements prior to robotic assisted surgery, we really didn't have very many options in terms of the tools. So our tools were very restricted. So if you were 7'2", or if you were 4'9", we generally made the cuts the same, which is really crazy. It makes no sense, right? Because everyone's different and everyone's anatomy is different. So the problem is that it was, the guides are based on a bell curve, and that bell curve, of course, are going to have great results for a good portion of it, and then they're going to be outliers. So what the robotic assisted surgery is allowing us to do is to get rid of those outliers and to give someone a much more customized total knee replacement. So potentials, I think, for patients in terms of the benefits is accurate placement and alignment of the implants will reduce the likelihood of dislocation. It will also it will reduce the risk of bony impingement, we call, where which is basically with movement, the implants or the bones hitting each other and causing pain. And it will hopefully increase your range of motion. Also will reduce pretty significantly the risk of leg length discrepancy, because there is so much lifetime feedback that we get that we're able to make, immediate changes at the time of surgery to make sure that all the corrections that are necessary are made. People ask quite oftenly, how long will it last? Unfortunately, it's impossible to really predict for any individual. There's a lot of factors that go into that, such as activity level, weight, age, bone strength. Materials are, much better than they used to be. And when you look, we have excellent 15-year data. We really don't have above 15-year data for a lot of the newer materials. What we do see is it's excellent in terms of, the survivorship. And what that means is that people have not needed to have them redone because they're wearing out. So we're really, really seeing very little problems with the newer style prosthesis. So overall, we expect hopefully the longevity to be much more than it used to be in the past. As Ruth said, I'm a specialist with revision surgery, so I do quite a few revisions annually, more than most orthopedic surgeons will do in their career. I do about 100 a year, and it's every revision is for a different reason, and they're all taken seriously. And a lot of them, we're seeing. I actually revised someone who had a total hip done 40 years ago, and it was striking that it lasted for 40 years. And I will tell you, the surgeon who put that in 40 years ago put that cup in a perfect position, which really gave it the best properties of wear. So the wear properties are highly based on how you put the socket and the stem in, and when it's put in an excellent position and you have the most optimal mechanics, you have a much better wear of the prosthesis. So this was very old material, which by our current standards was not very good. And it still lasted for 40 years because the bullseye was hit perfectly. And so what we hope, obviously, with the robotics and all this technology that we're using now, and all these, different approaches that we use to try to perfect the implant position, is that we will have longer lasting implants and better long-term results, especially with our younger, more active patient population. So in terms of recovery, every individual is different. Every treatment plan is different. I tell most people the first 2 weeks, you might be a little bit mad at me. Hopefully not too mad at me. The hospital stay, a lot of our patients now are going home the day of surgery. The grand majority, over 90%, are leaving within 24 hours. And, some patients will require more than that if it's a more complex surgery. Significant functional improvement, that 2 week to 3 month point, really 6 to 8 weeks, we see a pretty significant functional improvement. And then it takes really up to 6 to 12 months to see the full benefit. Some people do have, lingering inflammation and strength that they need to get. And so sometimes it does take a little bit longer to get the full benefit. This is one of my patients. We'll see if we can play the video.
Okay, tell me, how far out of surgery are we? What'd you have done?
Let's see, I had a total hip replacement, and it was 2 weeks ago in 2 days.
And how old are you?
I'm 83.
83 years old.
Going on
Great
84
shape.
in July.
All right. So you had a Mako robotic assisted direct superior hip replacement. Go ahead. Show us what you got.
Bionic man.
Bionic man. Show us how you're walking. Excellent. No cane?
No cane, no walker.
No pain with walking?
No pain. Just,
Excellent.
like
soreness.
1/2 of one.
Excellent.
Yeah.
Now, my disclaimer is that I do not video the people that are coming in angry at me. So not everyone will recover the same way again, but what I really saw in my practice was, I shifted over to two things. The approach with my hips is called direct superior, which is a minimally invasive approach, much more muscle sparing approach, but also the robotics. It was just such a significant difference in terms of how I was seeing people recover. And that's really what made me, stick with it and change my practice. What we look at in terms of failures of total joint replacements, some of the causes, like I said, the wear of the articular bearing surface. What that means is the wear of the surfaces that are rubbing each other. So in the knee, it's that durable plastic and the metal, and then in the hip, it's the same thing. It's the head with the durable plastic in the center of the socket. So in time, that can wear out. Again, with the newer materials, we're just not seeing wear as an issue. However, time will tell, and hopefully it'll be a very long time before we see that as an issue. However, the older ones, we did definitely see a significant issue with wear. Mechanical loosening, so the prosthesis, especially with total knee replacements, cemented in place. The cement can fail at some point in life, especially with kind of repetitive high impact activities. The question is, how long will that take? And, what can predispose you to that? Instability or dislocation. So again, that's really with both hip and knee replacement. With knee replacement, instability can be painful, and people can get recurrent swelling from instability, and their knee can give way. And part of the robotic assisted surgery is that we're getting live feedback. We call it dynamic balancing, because we're able to actually see what effect every change that we plan on will have prior to actually cutting the bone, which is really pretty amazing, because previously, once you cut the bone and then said, oh, I'm a little bit loose here, I'm a little bit tight there, then you had to try to chase your tail and kind of fix it. With the robotic assisted surgery, we don't have to do that. We can actually see what effect each change that we want to make will have prior to making the cut. So then when we cut, we already know what we're getting. And so we don't run into those issues. Infection can be a big problem with total joint replacement, and infection is very serious. And that's one thing we somewhat harp on in terms of weight and also diabetic control. Those are two things that are pretty significant risk factors that are obviously changeable. So we always talk about getting in the best shape you can prior to surgery, because an infected total joint is not as easy as just taking antibiotics. Often you require multiple surgeries to try to fix that. Periprosthetic fracture, what that means is there's some people have a total hip 10 years ago, and then they fall and they break their bone around the total joint replacement. The total joint replacement generally does not break. It's extremely rare because it's very hard metal. However, the bone around it often can fracture. And it's similar to what would happen if you didn't have the joint replacement there, but it is more complicated when there is a joint replacement there, because now we have to figure out how to fix that. And then there's, times where there's implant failure, also quite rare, and metal hypersensitivity, which is also extremely rare. So revision surgery, redo surgery, some people call it. It's a highly specialized procedure performed really by trained joint replacement specialists. it's an option for treatment depending on the cause of failure. So, there's, again, many reasons for failure. Fortunately, failure is very uncommon, but when you look at how many joint replacements in the United States have been performed, obviously a very small percentage of a very, very large number still leaves us with a pretty substantial amount of patients that do require revision surgery. Most complications can be successfully treated. It's very, very rare that that I see someone who I don't feel can, have a surgery that may benefit them in terms of a problem or a complication from a total joint replacement. At Providence, little company in Torrance, they've really invested in a specialized program treatment for these difficult cases, which is very helpful. I think it takes a team to treat these problems. These are not simple issues. These, take specialized therapists, specialized nurses, and really a whole team in the operating room as well, and an understanding that it's an investment for our patients and our patient population. So hopefully you guys got some good information, and happy to answer any questions.
Thank you, Dr. Wassev. That was a very, very informative lecture. And I'm actually very happy to see the video that you show is actually one of our patients. He was a lovely young man. So, and there's quite a lot of questions that's being asked, so we're trying to get through them. But before we do that, I actually wanted to ask the audience if they can help us in answering some of the poll questions that you see on your screen, and give us your honest opinion. That would be wonderful, because we want to make sure that, when we do this webinars, that we want to make sure we're addressing everybody's needs. So, so why don't we go ahead with the question and answer here. Let me pull it up here. So the first question that was asked, I still have the right, one of the patients says, I still have the right conserved cobalt chrome in my right hip. The left right cobalt hip was removed in 9/20/13 due to high level of cobalt in my blood. My level has increased to 1.5 and the hip pain has increased. Do you have any experience in this type of issues?
So what that's talking about is the metal on metal hips that were put in the past. And I do have a pretty significant amount of history with that, actually. One of the surgeons that I trained with in the past was actually one of the surgeons who put in quite a bit of the conserve metal on metals. And so I did see a lot of those and did, have to redo some of them that had failed. There was a lot that did very well, but I have revised quite a few metal on metal total joint replacements in my career. And it is, it's a very specialized and individualized treatment plan. Not everyone that has a metal on metal joint replacement needs to have it revised. However, if there is pain and there is any increases in labs, we generally are conservative about it and say we should probably treat that. So something that you should definitely have an orthopedic specialist and a joint specialist look at.
Okay, thank you. And then the next question, do surgeons plan each individual case ahead of time rather than just before going into surgery?
So with the robotic assisted surgery, especially, that's planned ahead of time. So the CT scan is obtained usually, 2 to 4 weeks prior to surgery. And then that's put into a special system, and that special system gives us a 3D reconstruction and a proposed plan. And then we kind of begin, we begin there, and with the engineers, we kind of make our specialized plan. Even prior to robotic assisted surgery, most surgeons plan their surgeries prior to the day of. But this is, the difference is now we have so much information in our fingertips that there's actually change that we can affect by planning for the surgery.
Okay. The next question comes in from Barbara. Says here, if I'm taking a long-term aromatase inhibitor, which supposedly leads to loss of bone density. Is my hip implant at risk, or would it be a bad candidate for knee replacement?
So good question. Bone density can affect joint replacements in terms of the overall fixation. Now, does that make you not a candidate? Extremely rarely. I mean, I've had patients in their 90s, and actually my oldest patient was 103, and I still had a hip replacement, and it was an urgent surgery, but she successfully healed, and she went on to be just fine. So, it's very rare that bone density will preclude you from a joint replacement. However, it can place you at risk for a periprosthetic fracture because the metal is so much stronger than the bone. If you fall, it's a very obvious place where all the forces will transmit to, and that's past either above or below where the metal is, and so it can make it a higher risk of failure.
Okay. The next question comes in from Shannon. Can infection be an issue for long after total joint replacement?
Yes. Infections can occur anytime in your lifetime. So there's different classifications of infections that we look at, and there's acute and we call chronic infections. So there are patients that, the higher risk is within the first 6 months of surgery. Once it happens after that, it can happen 10 years after surgery. I see patients sometimes 10 years after surgery who had an abscess infection in their tooth or something like that, or an infection somewhere else in the body. It travels through the blood and it hits the metal. And once the bacteria sees the metal, it's like a playground, and they make it their breeding ground. So there is definitely a lifetime long risk. And that's why we always tell patients that, you do need to be cognizant about it. It is metal in your body, and so you do need to be somewhat careful. And any infections you get, such as a urinary tract infection or any real infection, you should treat it more efficiently and more eagerly after you have a joint replacement. And the same reason why we give patients antibiotics before going and having dental work. All those things are to try to reduce the risk.
All right, the next question is, what are the materials they're made from? I guess I'm assuming it's an implant. What are the materials?
So there are different options, but overall, the majority, if you look at a knee replacement, the majority is a mixture of titanium as well as a cobalt chrome alloy. And those are the metals. And then in the center is the very durable plastic we call polyethylene. And that's really what acts as we call it the bearing surface. That's what really kind of gives you your cushion. And that's what wears out. The metal does not wear out in extremely rare circumstances, but it's not the metal that wears out. It's actually the plastic that wears out. And the older versions, the newer versions, we're really not seeing that as an issue. With hip replacements, it's mostly titanium, both the stem and the socket. It's mostly titanium, and then also a mix of ceramic or sometimes metal, and then the durable plastic as well.
The next question says, how would I know if I have a metal sensitivity?
That's a good question. So metal hypersensitivity was kind of a hot topic. There was a time in I think the orthopedic community where anyone with a total knee replacement that was painful, we just said, oh, it must be metal hypersensitivity. One of the surgeons who did a lot of the research on that and kind of coined some of those phrases was actually one of my mentors that I trained with. And what we saw is it's true metal hypersensitivity is extremely rare. Most people will have had something in their lifetime that they know that they cannot wear certain jewelry, or they cannot wear any metals outside of pure gold, or things of that nature. And not just the ladies that are telling that to their husbands so they can get the good stuff. The real hypersensitivities that get severe rashes and severe outbreaks. Sometimes we send patients for certain testing to help give us a clue. However, we haven't actually found foolproof, excellent testing for that. So it is a difficult diagnosis, and it's really there's multiple things for us that we look at to really diagnose that, but it is quite rare. And I've had patients that thought they had true hypersensitivities, that said, oh, I can't wear anything with nickel in it, and still have done excellent with a standard knee replacement. So.
Okay. Is robotic surgery done for shoulder replacement?
So they're not yet. It's definitely in the pipeline, and we're expecting it to be hopefully in the near pipeline. They've poured so much energy into the hip and knee as of now, and we're working on kind of the next iteration with the hip and the knee, and the next iteration of the knee is coming actually pretty soon, and it's pretty amazing. The shoulder will be definitely coming. There is navigation that's available, and there's CT scan guided guides that we use that are extremely helpful, but not true robotic arm assisted surgery yet.
Okay, can you comment on fixing osteoporosis in the ankle, treatment versus surgery?
So osteoporosis is not treated surgically. Osteoporosis is actually loss of bone density. Osteoarthritis, maybe that's what they were referring to. And osteoarthritis for the ankle, I don't do ankle replacements, but there is options for ankles of fusion versus replacement, and that's really a pretty highly specialized field in terms of which options are better for you. But there are ankle replacements that are being done successfully.
Okay, what is the difference between total and partial knee replacement?
It's a great question. So partial knee replacements, it's a excellent surgery. I think it's one of any robotic surgeon's favorite surgeries because people just do so well. The partial knee replacement is performed for patients that have isolated arthritis in one area. So when we talk about the knee, we consider three major compartments. There's the inner portion, the outer portion, and then the portion under the kneecap. And usually when we're performing a partial, it's the inner portion because most people have that area affected. A lot of times it's people that have had maybe a tear in the meniscus or an injury to one area of the knee and it becomes arthritic, but the rest of the knee is great. It's a really, really good treatment plan. If you look at the robotic assisted surgery, Mako actually started as only partial. That's where it really began. And then it went on to have total hip and total knee. But there was many years of just partial knee replacements. And the robotic assisted surgery had such a significant increase in terms of the overall success and survivorship when performed robotically assisted versus just normal manual. And that's really where the success of robotics started. So it is an excellent surgery, but only for the patient, for the right patient. The worst thing to do is a partial on someone who has arthritis in other areas and they don't do very well. So we really, only use it for people that have very isolated arthritis in one area.
Okay, I know we're going over a little bit of time here, so maybe we can take about 3 questions. The next question says, how would a hip replacement impact downhill skiing?
Well, hopefully you're not tumbling. Hopefully you're a good skier. That shouldn't affect it too much. I have a lot of skiers. I will say I think it's more critical with the knee replacements. I think knee replacements, the torque on the knee, especially with the turning and stopping, is a little bit more difficult if the knee replacement's not executed really perfectly. With hip replacements, it's pretty rare that people aren't able to get back to their, full-blown, really aggressive skiing.
Okay. The next question says, how invasive is Mako robotic surgery for hip replacement comparing to more common procedure? I had the patient had a TGR on my right hip almost 2 years ago, and that scarring experienced occasional tingling sensation during sleep.
So I'll tell you, robotic surgery can be used really from any approach, and so the invasiveness of the actual scar is, not drastically changed unless the surgeon really works at, using the robotics to minimize the amount of soft tissue exposure that they require. And that's really where I think it's a home run, when you kind of use it in a sense where you don't have to get as much exposure because you're seeing so much more with the robot. The one thing that we have, so the minimally invasiveness is actually in the amount of soft tissue damage. So there is a substantial decrease in soft tissue damage because the saw or the burr, whatever we're using for the procedure, is kept in a very, very strict boundary. We call it haptic boundaries, and it's pretty amazing. It's actually in space while we're moving our hands. We can't move it outside of that boundary without the saw shutting off, or it's stopping you. So the amount of soft tissue surrounding the area we're working on that's injured is extremely low compared to normal manual. So we do see a quicker recovery and less soft tissue damage.
And I think for just one more question, and then we'll end it. Is it advisable to have meniscus tear be repaired if you have on a displaced fracture of knee? I'm not sure.
Yeah, that's a very very specific question that you'd have to really look. I mean, a meniscus repair is performed for acute injuries to the meniscus. Sometimes it's an excellent procedure. However, not all meniscus tears can be repaired. In the fracture setting, that often is repaired in a fracture setting. If it's we call it a tibial plateau fracture with an associated meniscal tear. However, that's really dependent, on the exact situation and the patient.
Okay. Well, I think we're up to time here, and we're actually a little bit over here. So I want to, in closing, really, I want to thank everybody for taking the time to join to this webinar here. And most of all, I really want to thank Dr. Wassef for giving us this, really informative lecture. And we're looking for having more lecture in the next few months. So, look out for some our flyers. And with that, I think I'm going to end it. And thank you, everyone, for joining us, and have a great rest of your evening.
Thanks, Ruth. Appreciate it.
Thank you.